The broadcast is now starting. All attendees are in listen-only mode.
Well, hello, and welcome everybody. This is Dr. Evan Gwilliam. I'm the clinical director for PayDC software, and I'm just introducing your speaker for today, who you probably already know. Just a couple of things before I talk about Dave. We have another CE webinar coming up next month. Watch for announcements about that. The focus will be about diagnostic coding and documentation, and so that'll be, I think it's the middle of next month, and we'll let you know more as it gets closer. This is a CE-based webinar, which means that in order for you to get the credits, we have to prove that you were here and that you paid attention. So as soon as this webinar ends, you will be given a link to a survey to answer some simple questions about the content and then to give us a little feedback on the presentation. And so make sure that you stick around and do that. If you miss it, you should get an email within an hour inviting you to do it again. So just make sure you answer those simple questions so that we can give you your credits, and plan on about 6 to 8 weeks, maybe a little bit longer to get those credits. It takes a little bit of time to process those. So if you have questions about any of that, feel free to reach out to us and we'll do our best to keep you posted. Now, as we go throughout the webinar today, feel free to submit your questions. We'll make sure that we have some time towards the end for Dave to answer those, and I can jump in if necessary. A little bit of background information. Let me tell you how Dave and I met. It was working on audits for attorneys, looking at doctors' records. And I came into PayDC because Dave and I were looking at records and working on these things. And we were working together, and we saw eye to eye on this. And we were helping doctors get better compliance, win these cases. And so he and I know what's going on out there in the field and what needs to happen. And so we make sure that stuff gets into the software. And that's kind of part of, I have a lot of pride in that with our program. And so Dave is a certified coder, auditor, compliance specialist, and he and I have worked together for several years now, and he knows what he's talking about. Care plans is perhaps the most important piece of a chiropractic record and the documentation. So the stuff he's sharing with you today is critical and very important. So without further ado, Dave, take it away.
Thanks, Evan. I appreciate it, and welcome everybody. We're going to be talking about chiropractic care plans. And again, as Evan said, just make sure and stick around if you want the CEs to answer those questions. And also, if you have any questions, we'll go through and try and answer them to the best of our ability. So welcome, and I hope everybody enjoys it. Let me get started here. All right. So one of the things that you've probably heard me say, if you've listened to me talk about documentation, is that documentation is the story of how you cared for your patient. And obviously, the goal is to tell as compelling a story as possible. If your story says the same thing over and over and over again, obviously it's not going to be very compelling. There's going to be highs and lows and potential setbacks and wins, and all of that is absolutely relevant to your documentation. Now, remember also, it's not just your documentation that tells the story, it's your diagnosis codes, it's the levels of service tell a story. Modifiers, they also tell a story, how a particular code might have changed, and then of course our fees also tell a story. But we're going to be focused today on one key aspect in the story, and that's the outline of your story. That is what a treatment plan is. So you as a provider, you know, if you're going to write a book, before you start writing a book, there's a very good chance that you're going to be doing an outline prior to doing that book. And that's what your treatment plan is. And so we're going to focus on what should be included in a treatment plan, why, and give you some tips on how to make it better. Okay. Now, when it comes to documentation, I found that most doctors feel like, this is Steve, this is one of my bulldogs, and that's what happens when he gets upset with his brother Hank stealing his ball. So most of the time, I think doctors don't like documenting. It's a necessary evil, but we got to push through it, and we got to be very careful with it. Now, when we're talking about compliant care plans, one of the things that I often see is this 3 times a week for 4 weeks, 2 times for 6, 1 time for 12. That's 4 exams, 36 adjustments, 12 modalities, 16 therapies, $2,800. And because I like you, I'm going to give you a 20% discount. That is not what we're talking about here. This is more of a treatment schedule. That's all it is. It's a treatment schedule. So when you're going through and thinking about your treatment plan, there's much more to it than a simple treatment schedule. Now, the care plan tells what you're going to do and why, where you're going to do it to and for how long, the phases or stages. So you're going to have different benchmarks as you go through care. Your frequency might change, your goals might update. You're going to be doing reevals, and maybe you move from passive to active care, a combination of the two. Those are really important benchmarks that you need to document. And then you want to make sure that when you're setting up your care plan, you give the patient the best case scenario possible. If you go into this thinking, all right, well, I'm going to need to see you for a year, well, not only a patient probably won't like that, but payers, if they get a hold of the treatment plan, aren't going to appreciate that either. So why is a care plan important? Well, Medicare requires that you have a care plan. And one of the things that you're going to see that we do is we combine not only requirements for Medicare for chiropractic, but we also look to Medicare for physical therapy services or physical medicine services. And the reason for that is most DCs don't just adjust. They do modalities, therapeutic procedures. And while we only get paid from Medicare for our adjustment, we still do all the other services. So we should pay attention as to how to do a treatment plan for all of the things we do in our practice. Boards of examiners, they require a treatment plan. It says very clearly, and every state board requires, it either says a plan of care or a treatment plan. And by the way, I use the term care plan and treatment plan synonymously. Insurance carriers, they all require a care plan. And by the way, most of the time, they simply plagiarize what Medicare says and the requirements there. And then, of course, today's patients demand them. And the reason for that is because the more, the line shifting from what was third-party reimbursement to more patient reimbursement, co-pays, deductibles, co-insurance, there's more burden on the patient to pay. And they want to know, okay, what do I need? How long is it going to take? And of course, am I going to get better? So those are all very important aspects as to why you do it. But it also, what it does is it shows that you've taken the time to go through the decision-making process as to how you're going to get this patient better with the longest lasting results. And you've thought through it, you put a plan together, and now you're going to go out and try and follow it. So there's another compelling reason, and that is that the OIG, which is the Office of Inspector General, they're like the policemen for Medicare, and they did this report in 2009, and basically what they said is, look, it's a requirement for DCs to have treatment plans, but it's very common either not to have it or it's verbal and it's not written down. So you put down the frequency, but the rest of it kind of is just a discussion with the patient. And one of the auditors said, I rarely saw documentation of plan which included frequency, duration, and goals and objective measures. While they're in the manual, they apparently have not been incorporated into the profession. So it's still a struggle. These things, what you're going to do, why you're going to do it to, where you're going to do it to, and for how long, and measure objectives, that's what you want to try and accomplish with a treatment plan. If you look to Medicare, and this is from one of the LCDs or local coverage determination from NGS, plan of care should be individualized for each patient and should include recommended level of care, which is duration and frequency, specific goals with documentation of progress or lack thereof within the clinical records, and then objective measures to evaluate treatment effectiveness, qualitative and quantitative. So that's very clear as to what should be included. And that schedule of care that I showed you, while typical, that should be used more to discuss with the patient at report of findings time. So I wanted to give you this overview of what, if you're thinking about, all right, what should be included in a care plan and how do payers see it, from a utilization review. overview for most payers, this is what they expect to see. So first of all, patient comes in and make sure that they document a complaint. Okay, I was doing an audit recently, and the reason for one patient that they were there was because they received a coupon in the mail. That's not a complaint. You got to make sure you got a complaint. Then the provider performs an examination. Once they do that, you are going to identify some sort of functional deficit, loss of function for that patient. You then develop a treatment plan or a care plan. After you start, or when you start, typically if the patient's in a lot of pain, you're going to be starting off with more passive care, where the patient is passively receiving it. Maybe if you're doing stim or ultrasound, manual therapy is mostly passive in nature. Your adjustment is mostly passive in nature. Those types of things, traction. Then they expect to see, usually after 30 days, a reevaluation that compares what happened in the initial exam to that reeval, and then they're typically expect to see the patient receiving more active care. Now, you can combine the two. It can be passive and active at any point, but again, they want to see patients getting actively involved with their care. For example, I'll bet most of you prescribe exercises for that patient to do at home. Well, if you were to prescribe those exercises and show the patient, let's say, on the first time through, and demonstrate or have the patient do them in your office prior to going home, and you spend at least 8 minutes doing that, you can then bill for therapeutic exercise. If you're getting the patient to work on range of motion, flexibility, strength, things like that, you would be able to bill a therapeutic exercise showing that patient. And what that does is, again, it's about that story. It tells the payer that, hey, this doctor is getting that patient actively involved. Once they do that, expect to see a reevaluation, and then, of course, hopefully a release into wellness care at the end. There's got to be that end point at some time. Okay, so again, this is generally speaking. Now, what is a care plan? Well, I look to the Code of Federal Regulations in regards to outpatient rehabilitation. That's the physical medicine side. And then the carrier's manual in regards to chiropractic services, as well as the LCDs, and I just showed you that. And that's where we came up with the plan. And if you're using our software, you've seen the wizard. That's all based on that federal law. So remember, the care plan is the outline of your story. You want to create a best case scenario for each care plan that you create. Again, the long-term ones, those are probably not going to be very well received by the payers, including Medicare and or the patients. And you can change the fit. You don't have a crystal ball. When you're going through and developing the plan, if patient exacerbates, well, guess what? That might extend out your plan, or maybe the patient's going to get better quicker. Those are things that you got to look out for. And I like using templates to simplify the process. I'm going to show you how I build a template and some of the things that I incorporate into that. So what is included? What specifically does Medicare say that needs to be in a treatment plan? Well, the first thing is you got to have a diagnosis. Okay, you've done your history, you've done your exam, and then it's time to develop the plan. And Medicare says that the plan should be done before treatment begins. So keep that in mind. And again, I like writing out diagnoses. I don't just like putting in a number. The second thing is you want to make sure that you identify specific services. So for example, if you're going to do therapeutic exercise, put down what kind. Or if you're going to do electric stim, put down the type of stim you're doing. Or if you're going to do manual therapy, what kind of manual therapy. That really helps to identify the service, and it's a very key aspect to your story. The frequency, times per week, duration, and the number of weeks that you expect to provide that particular procedure. Goals and rationales. And you should have both long and short-term goals. And we're going to talk about that. I'll give you some examples. And stages or phases of care, those benchmarks. And by the way, this is something that I've added. That is not a Medicare requirement, but I think, it helps create a better outline and tell a better story for your patient. And then it's got to be signed. I can tell you that so frequently do I see documents that aren't signed, and that can be problematic, especially if you get a request for records and you're sending things in. You have to have those signed. And I know if you got EHR, PayDC has an electronic signature, or whatever you might be doing, make sure that everything's signed moving forward. Now, oftentimes doctors say, you know, how many visits can I do? What's reasonable? And obviously, having everything in a cookie cutter fashion, that's not something you want to do. You don't want to have everybody get the same thing over and over again for every visit. That becomes an easy target for payers to say, huh, why does that all those patients get exactly the same thing every single time? I'm dealing with an audit right now for that. And remember that the treatment should be based on complicating conditions, exacerbations. Maybe there's environmental things, like, for example, if the patient walks with a cane, you might want to mention that. Or if they in a wheelchair, or they do a lot of heavy lifting at work, or they sit at a computer all day. Those things will affect treatment outcomes. Or maybe the patient has diabetes or is obese, or those things you want to make sure and note. And often really take a common sense approach to care. I once had a call from an attorney who said, Dave, I received a call from a provider who's being audited by the insurance company. And I said, okay, well, what were they doing? Well, he said that for every visit, the provider was doing her adjustments. You know, she was adjusting the patient, but then she was also billing for 8 units of therapeutic exercise, so 2 hours of exercise every day. And, you know, I was thinking about it. I said, well, Medicare does allow for up to 2 hours of therapy per day, so I guess it's possible. What was she doing? And he said, well, there's the issue. The patient had neck and shoulder issue, right shoulder issue. So the doctor went out to Home Depot, got some tarps, got some paint, some rollers, paintbrushes, moved everything out of her office and tarped everything, and had the patient paint the office as therapy. So make sure you use a common sense approach to treatment plans. You know, the show me paint the fence Karate Kid treatment plan probably is not the best option for you. So in any case, that's a true story, by the way. I did, by the way, recommend that they pay the money back. So you want to get more visits. I know that there's a lot of utilization and management from third-party firms that limit the number of visits that chiropractors can get. And for chiropractors, all providers, but specifically DCs, it's really, really frustrating. So I get oftentimes asked, Dave, how do I maximize the visits? How do I show them that this patient needs more services? And if you send in a plan to the payer and you get 6 visits, and if you want to just keep it at that 6 visits, you get right in that bullseye in the middle, and that falls in with their utilization review guideline. But 9 times out of 10, you need to get more visits than that. You got to go outside of that little bullseye area of that 6 visits. So you can have the best documentation. You can create a fantastic treatment plan. That's excellent. But it still often falls short. You want to also incorporate some scientific literature. Maybe you go to the Clinical Compass and get some peer-reviewed information that identifies how many visits a patient with a sprain, strain, low back sprain needs. Or maybe you go to a medical resource that identifies it. Or, I mean, there's a lot of ways that you can look and find research that backs up what you want to do and the frequency by which you create that plan based on it, and you can be successful. I had a provider out of Texas who had got a referral from an orthopedic surgeon. The patient had neck and shoulder pain. It was a post-op rotator cuff repair that he had to rehab along with some neck involvement. So he developed a plan of care. and asked for 24 visits. He sent it in to a company, but starts with an A and ends with an Ashen, and they denied. They said 6 visits, and he said, "Wait a second, 6 visits? I can't possibly get it done." So he looked up at the American Academy of Orthopedic, I forget the exact site, and found out that a research study that said that the minimum is 24 visits. So what he did was he sent that in along with his plan of care, and guess what? The payer allowed for all 24 visits. So what he started to do is he started to create a little library based on that clinical research, and would assign that and attach it when he sent in to this particular company to try and get approval. And he started to get approved for all of this, and pretty soon he stopped having to send those in because they recognized that he knew what he was doing and they would just approve the visits. Now, results can vary, obviously, but it's something, it can give you a little boost if you take the time to do that. So I'd go on, I'd Google it, and see what you could find out there. So when it comes to duration and frequency, you could create a trial, okay, that's based on evaluations, and instead of a long-term treatment plan, it could be smaller treatment plans. CMS, of course, recognizes that acute treatment is shorter in duration with higher frequency, and that chronic treatment is longer but less frequency. So, even Medicare recognizes that. I think every payer will recognize that. But if you are in a situation where you're seeing your patients once every couple of weeks, and a lot of patients, guess what? That is likely to stand out to a payer. So be very careful to document those chronic situations that require it. I would use, again, clinical expertise and research, patient expectations, and then any guidelines that you can possibly incorporate into that. That makes sense. And then use that to help really get approved for as many visits you can for your patients. Now, another helpful thing might be this LCD L35424 from Novitas. So Novitas has specifically identified what diagnoses warrant up to a certain number of visits. So they created these group A, B, C, and D diagnoses. So group A diagnoses, and there's just some examples here, allows up to 12. Now, not everybody's always going to get 12, but it's up to 12. So you can see those are more symptom type diagnoses: pain, dorsalgia, contracture of muscle. Those are the group A. They allow for the least amount of visits. Group B, spondylosis with radiculopathy, and so on. Those allow up to 18 visits. Group C, the spinal stenosis, cervical disc disorders, those allow up to 24. And group D allow up to 30. Those are the sciaticas, the radiculopathies. And again, this is for Medicare. And if you're not part of this MCO or Novitas and you're some other, still it gives you a good insight as to what probably most Medicare contractors are thinking. And it will also, in the private payer sector, it will help you identify which diagnoses are going to allow for the most care for your patients. Now, you can't just assign them without the patient having them, of course, but if they do have these, you're going to want to make sure that that group D diagnosis is listed primary on your CMS 1500 form when you're sending these claims, and it's listed as a primary in your documentation, the assessment portion of your documentation where you're listing your diagnosis. So this can be very helpful. I would look up this LCD. Again, LCD L35424. You can just Google Medicare coverage database, look for the LCD there, and take a look and record those diagnoses. Now, when you're talking about weak care plans, again, they only address frequency, duration, and neglect goals entirely. I just had a provider right now that's being audited by a payer, and there's 0 goals identified. Well, in fact, he doesn't have a treatment plan. It's just frequency, and there's no goals, nothing to draw. Or maybe I see goals, but they're only subjective, and They don't address function, and they're not measurable. Those are very key aspects when you're assigning goals. Short-term goals, reduce pain by 10%. At least that's measurable. If you're going to have a goal of strength, you have it documented that the patient has a loss of strength. If you want to increase endurance, are you going to say the patient is frequently out of breath or what have you? Maybe they're obese, something like that. And what about the ability to move? Maybe it's range of motion. Maybe it's pain-free range of motion, something like that. So, really think about the cause and effect when you set your goals. What about ADLs, activities of daily living? And be specific. Don't just say, I want to increase ADLs. Maybe get 5 to 6 hours of quality sleep. Excuse me. And put down in what time frame, okay? Stand for more than 20 minutes, sit for more than 20 minutes. Maybe it's an hour. Maybe they're a truck driver and you want to help them be able to sit pain-free. Maybe it's walk up the stairs without assistance. Maybe it's walk more than a block, or walk a half mile, or lift 20 pounds off the floor. Things like that you can measure. So you set the goal, you identify where that patient is in their at the current state, and then you can say, hey, after 4 weeks we want to be here, and so on and so forth. Also, outcome assessment tools, okay? And you can really go, if you're looking for ideas, pull up an Oswestry, okay? Improve NDI from 60 to 30% by reevaluation time, or enable patient to lift heavy weights without pain by blah, blah, blah. Now, heavy weights, I don't know is really something you want to do. I'd give it a specific pound, but again, these are some ideas. And what about improve ability to stand without pain from 30 minutes to 1 hour? Again, that's from Oswestry. So take a look at these, and that's the NDI, the Neck Disability Index. So think about what you want to do and how you want to do it, and you can incorporate that right into your long-term goals. 10% improvement according to Oates is minimum detectable change, 30% is meaningful, and 50% is substantial change, okay? And every 30 days, at reevaluation time, have the patient fill one of those out, or at least address the long-term goals that you've set for that patient. Very important to do. And use that overall Oates score as a long-term goal, and identify, hey, I want to reduce it to X or Y. And for major injuries, the overall Oates score might work good, because those chronic cases do go up and down and stuff, and that can really help you out. So just some thoughts here of how you might be able to do that. So when you're going in and doing a treatment plan, you want to make sure and use a template. I strongly recommend that you use a template when you're creating these. So what I like doing is starting with my best worst case scenario. What I mean by that is, look, take the typical patient that comes into your office, and the most difficult one, maybe it's a full spine type patient, and start there. And then what you can do is, once you create that treatment plan for that patient, then you can pare it down. You can focus, then it makes it easier to do just a cervical one, or maybe a cervical and shoulder, or maybe thoracic and low back, or maybe it's low back and hips and what have you. And it really helps to do that. Identify the stages or phases of care, okay? Create those benchmarks. Well, in the first 2 weeks or the first 4 weeks, we're going to be intense. We're going to be 3 to 4 times a week, and so on. And then after that, we're going to move into a corrective phase of care, and we're going to back off some of the visits. And then finally, when we get to the strengthening phase, we're going to go ahead and bring you down. We're going to do more stuff at home. You're going to be actively involved, and so on and so forth. Determine what services you typically perform for each stage, and be specific. Don't just say manual therapy or therapeutic exercise. Put down the specific types, the times per week, the number of weeks, and of course your rationales or goals. And again, both long and short-term goals. Of course, the long-term goal is going to be overall, but within your phases or stages of care, you're going to have the short-term goals. And those are going to be really tied to, short-term goals are tied to specific services. For example, your goal for muscle stim is reduce pain. That's the only thing that interferential really can do. But your goal for manual therapy is going to be, reduce contractile and non-contractile tissue extensibility, improve range of motion, things of that nature. So again, you're going to be doing that. And you could even be more specific, which we'll get to. What I like doing is I like going in and creating the stage, identifying all the specific services that I do, including the specific types, okay, where I'm targeting, the times per week, the number of weeks, and then what my goal or rationale is for that. So here's an example of an intensive phase. It's a 4-week phase of care for this patient. So we're going to do CMT to the spine, and we want to reduce pain from 7 out of 10 to 4 out of 10. So you can see in a 4-week period, I want to get them down 3 points. Okay, I want to reduce measurable range of motion restriction by 50%. So obviously you're going to have identified a loss of range of motion. And I'm also going to do EMS to the cervicothoracic region. We're going to reduce pain 7 out of 10 to 4 out of 10. And I want to reduce palpal muscle spasm, okay, because I'm doing high volt. That would allow me to do that. I'm also going to throw in some ice. Again, you're not going to be reimbursed for this, but it adds to the story to reduce palpal swelling. And then myofascial release 2 times a week instead of 3 times to the right deltoids to break up palpal muscle adhesions and increase range of motion by 50%. So if you go in and develop this first phase, and then develop the second phase, and then the third phase, and maybe you have 4, maybe you have 2, whatever the case may be, this becomes easy to build off of. And also for different injuries, your goals for doing myofascial release are going to be the same, but maybe the area is just going to change. And for the areas of the spine might change, or where you're going to be targeting the stem, but you're still going to use it. Think of like a housing development that has 3 or 4 model homes. When they sell that house to a particular family, well, they're going to have different landscaping, they're going to have different painting, they're going to have different furnishings. It's still the same model home. Think of your templates like that model, and then you're just going to customize it to fit that particular patient. And you can save these and use them. And what it does is it makes your daily notes that much better, because you can point to it. You don't have to write down every visit why you're doing something. You say, as per treatment plan, and point to it. Makes it very effective. Here's an example that we have. And if you look at the long-term goals, enable patient to sit pain-free for 1 hour at the computer. Currently, patient only sit for 5 minutes pain-free, also restoring tolerance to normal ADL. So you can see that's specific. It's something that I can measure and comment on every week or 2 weeks or whatever you want to, and that is very measurable. When it comes to my short-term goals, you can see I give it a number, it's for a particular time frame, and I get as specific as possible and show that's something, again, that I can measure. As I move through, okay, you can see I go in and change that. Now, when you're identifying these goals and you're moving through the different stages, you should get at least to increase at least 50%. You want it to be as measurable or as valuable, as meaningful, as possible when it gets to these goals. When it comes to a prognosis, now you want to make sure and identify a prognosis, and short-term is symptomatic, long-term is functional. And I stole this from Dr. Evan. And you can see here we've got this grading scale: excellent, good, fair, poor, guarded, and unstable. So excellent means, hey, 2 to 4 weeks, this patient is going to be full symptomatic and functional recovery in 2 to 4 weeks. If you choose good, all right, that's in full symptomatic and functional recovery 4 to 8 weeks, all right? But they might have some mild intermittent pain and restricted motion and so on. So there could be some little tweaks here and there, but generally speaking, that's what that means. Fair, you're going to have a reduction of their symptoms, but they're going to have some persistent pain, stiffness from the injury, and may require some ongoing rehab. Poor, hey, guess what? It's expected the patient can continue to experience this intermittent occasional paresthesias or what have you, frequent pain, and they're going to require care. So keep these things in mind. You've got guarded and then, of course, unstable. So you don't want to have a patient set in a particular prognosis forever and ever. Obviously, there's going to be times where a patient's unstable or guarded or fair or poor. And you want to, when you identify that, you want to try and update that prognosis at least at every reeval. And if it changes, guess what? You want to say that. It really helps to tell a better story if you're going to be doing that. So make sure that you go through, you identify that, and you do that to the best of your ability. Okay? So when you're doing these treatment plans, okay, what payers and of course Medicare expect from a treatment plan is, okay, so how are you reaching those goals? Okay, so you should be commenting on that, and again, in different phases or stages at reeval time, comment on how that patient's doing towards the goals. Is the patient being compliant? I mean, you could go through and you could actually put down, you know, that the patient, hey, the patient is on vacation, so this is going to hinder the care plan, or the patient isn't being compliant with the visits that we expect. And I know a lot of you have that same problem, but you should be documenting that. I think it's absolutely very relevant to your story. If I'm reviewing your records and have to ask, now why did the patient not come in for 4 weeks? Well, they weren't compliant. I tried, I did this, but that's never documented in the record. And what you explain to the patient and how their actions are actually going to hinder the healing process, that is something that you should absolutely be documenting. As the conditions improve, are you decreasing in frequency, or are you changing the number of regions that you're adjusting, or are you always doing a 98941 each and every visit regardless? So as the patient complaints resolve, your diagnoses are going to update, your treatment should update, and again, you want to that makes for a much more compelling story. Are the goals changing depending on the condition? All right, if it's not improving, hey, maybe you have to send your patient out. That happens all the time, and so you want to make sure that you really identify that. And you know, it's common sometimes if a patient's not getting better with one treatment regimen, maybe you got to switch it up and say, hey, we tried this for 2 weeks, it didn't work, we're going to go ahead and try something else. And if the condition stabilized without expectation of improvement, are you transferring on to maintenance? You know, you got to be very careful about going in and just trying to maintain a particular level of function. There's something called MMI, or maximum medical improvement. Now, I know I'm using that term medical, but think about it this way. You know, you've got your medical policy and you've got your chiropractic philosophy, and the two often butt heads. So you have to kind of separate yourself, and if you're dealing with third-party payers, they're the medical model. That's just, it's how it is. So you need to think about, okay, if I am just maintaining a particular level of function, guess what? It's time to cut the cord or time to change up the treatment. And I know it's sometimes hard to do, but you really need to make sure and do that. It's very, very important for you in being successful. And if the condition does resolve, are you going to discharge the patient, or again transfer them onto wellness? So these are all really, really important things that you need to be careful of. So again, creating the plan is one thing, and it's really is the outline of your story. But then you got to make sure and follow the plan to the best of your ability. I've seen providers that they get a request for records, and then they go through and they take a look at their documentation. And I had one doctor go back and say, you know, Dave, I didn't realize that over the last 2 years I saw this patient 200 times. Yeah, that's a lot over a 2-year period. And, you know, I really just didn't realize they were coming in. I'm not going to turn them away. So I just kept on treating them. We kept on billing, and then away we go. But that obviously is not a compliant thing. It's likely to set you up for an audit. So, you know, when you go through and you're ready to release that patient to wellness, one of the things that I often recommend to providers is use the it's the S8948. That's a HCPCS level 2 code. S as in Sam, 8948. and that is for physical or manipulative therapy for maintenance rather than restoration. Oh, excuse me, it's not S8948, that's laser. It's S8990. So excuse me, S is in Sam, 8990. That's physical or manipulative therapy for maintenance rather than restoration. So if a patient comes in and you need to release them for wellness, you can bill that code. Most payers will deny that, okay? And then the payer will see that you're released that patient to maintenance, and then the patient will see that that code is denied, and they're going to have to be financially responsible. Because I do hear from a lot of providers say, Dave, my patient has, they called up and they said, hey, you can get care, and if I bill an adjustment, which they want me to, they're going to go ahead and continue to pay. So use that. You could also change up your diagnosis. You could use from chapter, it's the Z chapter, and there's a lot of diagnoses that, for, preventing, or for exercise maintenance or whatever, use one of those codes as a diagnosis code as well. For Medicare patients, you can't bill the S8990. Medicare will not recognize that. So what you would do is you would simply remove the AT modifier and have the patient sign that ABN saying, hey, I understand that the care's likely not to be covered. They can choose whether they want you to submit the claim or not, and Medicare will deny it. So those are some ways that you can do that, combat that. But again, make sure that number one, you follow the plan, and number two, you cut the cord when you need to. And I know that's difficult, but it's something you have to do because payers do not pay for that maintenance care. Okay, so I know we have a bunch of questions. So why don't we go ahead? I left a few minutes to go through there, and then I know that everybody, you're going to have a quiz. So Evan, I'm going to turn it over to you. Yep. And let you go ahead and go over some of these questions that we have.
We've got a lot of good ones in here because this is a topic I think that can go a lot of different directions. So
right, yeah, absolutely.
I'm gonna dive right in here. And Dave, you might even want to pull up the software to answer some of these.
Okay.
So first question is, how would you indicate in your notes if a patient can only come in once a week or if your patients travel for work? Okay,
well, I would simply put that either as part of the plan or in the plan section. Just write that down and say patient only able to come in. Maybe you talk about some of the home exercises or stretching or things that you are asking them to do on their own, and then the rest is going to be done in the office at the schedule that you have. I mean, that's how I would expect to see it. And then if I'm a reviewer, which obviously both Evan and I are certified auditors, to me that would make sense, and it becomes okay, that makes sense to me as a reviewer.
So next question, same doc. He says, and this is from looking at the Medicare list from Novitas, I think. He says, how can we treat stenosis when that pathology will never go away? Why is it even on the list?
Well, I don't know why Medicare put it on the list, but again, you're going to get them to a certain point, and then you're going to be maintaining a particular level of function. Once you get to that, then that's where you're going to have to transfer them. So I don't know really any other way that you can do it. Evan, do you have any thoughts on that?
Yeah, so you're not fixing the stenosis, but you are treating the functional loss that came as a result of the stenosis, and Medicare will pay you as long as you can show that you are getting functional gains based upon the loss that you're attributing to the stenosis. So it's not so much the condition you're resolving, it's the condition that explains why the patient needs the treatment, which is functional loss. And once you no longer have functional gains, you're done. So good question. I like this one too, and this might be something you can show us too, Dave. This is from Dr. Glynn. He says, how often do we have to address the goals? Every visit or every other visit?
Well, no, I don't think there's a set thing. Your short-term goals you might address every visit. I don't know. The long-term goals, certainly at reevaluation time. So I think it really just depends on how you want to do it. But what I would do, I think short-term goals I would address at least weekly, and long-term goals at least at re-exam time every 30 days.
So Dave, maybe if you don't mind, we've got people on this who are not clients, or some more clients who don't utilize this feature. Would you just mind showing how the long-term goals tie into the SOAP notes at a daily visit with the slider?
Sure. Yeah, absolutely. So, oh wait, here, let me pull up the patient. I think Minnie Mouse has something in here. So what we do in our system is just as an example is when in the assessment portion, you can see I have this patient, and one of the goals is to enable patients to sit pain-free for 1 hour. Currently, patient can only sleep for 5 minutes pain-free. So what I would do, maybe it's a re-eval for this patient, now patient, sorry, I can't type, is able to sit pain-free for 15 minutes. Okay, so that gets me to about the 30% improvement rate, and I simply comment on it. Maybe it's every couple weeks that I do, but it's always going to be here, and I could always comment on it at any time.
Yeah, so you don't have to comment on it at all for 2 or 3 visits, and maybe you go, hey, you know what, I think we made a little 10% progress. So it's there available for you to add that in as needed. Great. So another question, actually, also from Dr. Glynn. He says, what if the patients don't follow the treatment plan? He says, about 100% of my patients don't follow the treatment plan exactly.
Well, you got to note it. You just got to say, hey, patient has not been compliant. Had discussion with the patient, about why their care is important and how it's going to extend out, and yada yada yada. I think that just tell the biggest lie in the world, the truth, and what's going on, and that your patients aren't doing it.
Yeah, and I think you can edit goals as you go along. You can edit the care plan and then include that more updated care plan and say, hey, we had to update the care plan because it turns out the patient's not going to do this. I think if you can just tell the story, put it in the notes, and away you go. All right, so what if you're treating a patient once a week for a year, but they're seeing other medical professionals for their problems as well?
Well, look, there's going to be exceptions to the rule. If you've got a patient with some sort of long-term disability and they require that, and you could show that you're helping to improve function, then, that so be it. But, just because the medical providers are doing something doesn't mean, you should necessarily be jumping in, because, medical doctors get audited just as frequently as chiropractors. I can assure you of that.
All right, here's a slightly different question from, I think it's Dr. Megwood. He says, because you're talking about the S8990, he says, what about FSA accounts? Will they reject treatment for S8990 if they're asked for a receipt?
I don't think so. That's a very good question. I think HSAs will reimburse for it. My HSA will reimburse for most, like, for example, if I go in and get a teeth cleaning, they'll pay for it, even though the regular insurance does it. So I think they might. I would go ahead and give it a try.
Yeah,
it's a legitimate HCPCS level 2 code.
Yeah, and I don't think that they have, medical necessity requirements.
I agree.
Spending, so I think you're safe. Okay, a patient with severe scoliosis of mine needs a longer duration of care. Can I request this of Medicare? From Dr. Lyon.
Well, I don't know that you can really request it. You should still, I don't know what state the doctor's in, but, like, for example, if you are in Pennsylvania, New Jersey, anywhere where Novitas is, Novitas allows you to add both a GA and an AT modifier. So what you're saying is that, hey, I think this is still active treatment, okay? But you have the patient sign an ABN that says, hey, there's a good chance Medicare will not pay more than that 30 visits or whatever number of visits is typically, allowed. So you can give it a try, and it could be rejected, but you might work out for you.
Oh, she just submitted. She said it's in North Carolina, which I think is Palmetto. But
Palmetto.
I know that several others are saying no, you can't use AT and GA together. And I think
you can in New Jersey, Pennsylvania. Novitas does specifically allow it.
Yeah,
I know that for a fact.
You just treat the patient as much as you believe they need, and let them audit your notes and prove to them that they needed it. Because
Yep.
those limits are not set in stone. They'll deny based on them probably, but then you go in and say, hey, I want to appeal because this is a special case. They got a really bad thing. They got scoliosis and so on. So I think you can fight for that with great notes. She asked a follow-up question kind of to that. Is you showed those list of diagnosis codes, but it didn't show the M990s. So where do they?
Yeah, well, that's a different category. You still have to have the subluxation codes, but these are just the causation codes. You know, what's causing the subluxation. So what you would do is you'd still list for Novitas, you still list the M99, 01, 02, 03, 04, 05, and then the secondary diagnosis would be the sciatica, and then you list another subluxation code, and then, you know, radiculopathy, whatever the case may be.
So here's a little different question. It's sort of out of the scope of what we're talking about, but it's worth answering. It says, can we charge a patient a lesser fee for a lesser service like maintenance, which is uncovered?
Yes, that's a great thing. You know, the S8990 typically would not include as much. You know, there's pre, intra, and post-service work associated with each code, and the wellness visits typically don't have as much of that assessment, of much of that intra and pre-service work. It's just the and post-service work. It's just going to be the intra-service work. So yes, I think that you absolutely can have a different fee for those, for the maintenance code.
Great, I agree. Here's a question from Dr. Schraden. He says, Medicare and AARP don't pay for extremities. What's the best way to document for a Medicare patient with left shoulder pain?
Well, you're still going to document it. You're still, if you feel like they need it, go ahead and adjust that shoulder. And even though Medicare doesn't pay for it, maybe the patient has a secondary. You add the GY modifier onto that. You're going to have the diagnosis, okay, in there. You certainly have the complaint. I mean, you can use an extremity. Medicare is just not going to recognize it. And the secondary might pay for it. And you could diagnosis point, show that the diagnosis for the shoulder is related to the extraspinal CMT, and maybe that secondary payer will pay it. Add the GY modifier showing that it's a statutorily excluded code. So in other words, they don't pay you for it, but it's certainly within your scope of practice to perform.
Hey, I'm going to add, at the end of the day, your notes should be like a script for a play. Like, regardless of who the payer is, if I pick up your notes, I should be able to reenact that scenario based upon what's in them. So you got to tell what really happened and what's really going on, and then figure out the payer kind of secondarily. So those notes should still include the information, you know? There's just a few more questions, and we have a few more minutes. So question from Dr. Megwood again. He says, if you keep your care plan pended and then edit it later, doesn't that overwrite your initial document? It's kind of a software question.
Yes, that would. So what I recommend doing, if you amend your care plan, amend it in the actual plan portion of the note. We've got, like, right down here, you have that freehand section, and you could go in and you can amend the care plan there and just identify that, how it changed. So you can do that. You can also finalize your care plan and then do a new care plan using the previous one. So what you would do is you would go in, and let's say that this was a finalized, you could just click create another care plan, and then what you would do is you'd say, when you got to here, you'd say use previous care plan, and then it'll create another one, and you just, you know, change whatever changed for this patient. So in other words, I would go in here, and maybe you're not going to do, all right, maybe you're in the rehabilitative phase, or maybe you're jumping to the strengthening. So you can do that because it saves it exactly the way it is, and then now you've got two of them. So those are your two options. Personally, I like just doing it in the plan because, you know, I don't know if you're just adding something in or you're changing something small up, or you say, you know what, they're going to need a few more visits. Mention it in the plan is something that I might do.
Yeah.
The plan section of the note.
You can tag in the most recent care plan if you wrote a new one, you know, so it's listed at the first visit, and then you redo it at the fourth visit. You can just add that care plan in again once it's modified. Yep. Excellent. A couple more questions here. Where in PayDC is the objective measures to evaluate treatment effectiveness? Would it be in the long-term goal comments? From Dr. Kuna.
Well, the objective measures to evaluate treatment effectiveness are kind of all over the place. First of all, you've got your exam. So So you've got all these objective findings in here, your ortho, posture, range of motion, strength, and so on. And in the assessment, you've got your long-term goals right here. And those are the two main places that you would find that.
Yeah, perfect. And then I just got one other question here. It's from Dr. Lyon. It says, can you say the treatment helps for a week or two? Actually, I'm not sure what she's asking. Can you say that the treatment helps for a week or two? So I guess she's talking about, like, what if you just treat someone for, a week? You're just treating them 2 or 3 visits. Oh, she's talking about scoliosis. Oh, so this is more like, you treat them and they feel better for a couple of weeks. And then, so how do you deal with that kind of a case? Like a chronic.
That's a tough one. First of all, some payers don't, if scoliosis is a primary condition, some payers view that as not medically necessary. That's been my experience. But, that's tough. Some payers do allow for a trial period of care, and that if the patient regresses, then they'll go and say, okay, guess what, it's worth it. So you try it, then you leave the patient alone for a couple of weeks. If they regress, they will allow that. Again, it's just going to be kind of a trial and error thing to see if the payers will pay for it. This is also something where you might find some sort of literature that backs up what you're doing and why, and might help with that, justifying your services moving forward.
Yeah, I think that the goal with payers, especially Medicare, is if you can show functional gains, as long as you can show functional gain, you can keep
covered.
But once there's no more functional gain, you got to charge the patient or something. And that's kind of just the way the payers work, unfortunately. That is majority of the questions that we got in, Dave. So I just want to let the audience know, I did throw in some hints in the chat on the quiz questions. As soon as this webinar ends, you will be prompted to complete the survey. So please take a moment to do that. We need that in the report we submit in order to give you the credit hours for this. With that, any parting comments for our audience, Dave?
No, I think that I hope everybody enjoyed it. If you have any questions, you can email me, dave@paydc.com. Just feel free to shoot me an email, and I'd be happy to answer questions. Also, remember to take the quiz if you're here for CEs. And Evan, I think, explained how to do that. Evan, you want to give them just a recap on that?
Just, I believe as soon as we hang up, you'll get a prompt to take you in and answer those questions. If you don't, you should get an email within an hour that will also take you back to answer those. And there's 5 quiz questions about the content, and there's 2 or 3 more about just feedback for us about how to make these even better. The next one is going to be, I can't remember the date, but it's the middle of May, so we've got about 5 or 6 weeks before the next one. Also, just to kind of get you guys thinking about it, we are doing a user conference. Dave, maybe I should announce that this early, but it's
no, I think the user conference is great. Yeah, we're having a user conference that everybody can attend. It is on, hold on one second. Evan, do you know the date? It's on the...
It's the May 17th, I want to say.
Yes, I think you were correct on that. Hold on, sorry. That was good. Yes, it's the 17th, May 17th at noon. It's going to be in New Jersey at the Hyatt Regency. There is a charge for it, but both Evan and I will be there. We're going to have Andrea and the rest of the staff, and we're going to go over some really cool stuff with the software and some things coming up and so on and so forth. So hopefully you'll questions. If you have questions about that, just email support@paydc.com. Love to have you attend.
Details are forthcoming on that.
Yep, absolutely. We're sending out emails. We're also going to be doing a pop-up on Monday, so you can sign up that way too.
All right. Well, thanks everybody for coming, and Dave, thank you so much for sharing your great wisdom with us.
Thanks, Evan, for being here and hosting and helping me with it.
Yep. Those of you who are clients, we're happy you're with us. We're doing our best to help you and make your lives as easy as we can. And those of you who are not clients, contact us and let us do a demo, and we'll show you how things could help you out and make your offices even better.
Thanks, everybody. Have a great day.
All right. Bye-bye.